Kia ora koutou katoa, no mai haere mai. Thank you very much for coming to today's stand-up. I'm joined today here in the room by Dr Andrew Old, who's the Deputy Director General at the Public Health Agency here at the Ministry of Health, and also to Whatu Health New Zealand's Interim National Medical Director, Dr Pete Watson, who will be on the screen shortly after I've gone through some slides as part of my opening comments. So welcome again, thank you for being here. Today, just starting with an assessment of the current outbreak of COVID-19, how we're tracking against the modelling, and also some analysis from our recent, an update on the recent analysis of our deaths here in New Zealand from COVID-19. And then I'd like to briefly discuss or refer to a directive that I've made to certain local authorities regarding water fluoridation today. Pete Watson will give an update on the health system's response to the winter pressures, which we know are very real. And finally, Dr Old Andrew will speak to the country's monkeypox response following, as you will be aware, the WHO declaring the virus and the current outbreak as a public health emergency of international concern. Turning to the COVID-19 numbers, today there are 8,730 new cases in the community, with 808 people in hospital. This is day 2 of our new approach to reporting deaths that are attributed to COVID-19, either as the underlying or contributing cause. There are now a total of 1,427 deaths confirmed as attributable to COVID-19, either as the underlying cause or a contributing factor. And the 7-day rolling average of attributable deaths is now 17. I've got some slides up here now to speak to, and you can see in this first slide that case rates are trending downward across all 4 regions in New Zealand. This finding is supported by what we're seeing from the wastewater results and the test positivity in our people being admitted to hospital. In the week to 24 July, the case rate from reported test results decreased by around 12% compared with the previous week. And pleasingly, we're seeing that case rate decline as well in our over 65s, who have had the highest case rates amongst our groups at the moment. And likewise, our hospitalisation rate to the end of last week did decrease, but you would have seen that the numbers did go up again over the weekend. They've come down again now to just, as I said earlier on, 808 people in hospital. This is our regional weekly hospital occupancy rates related to COVID-19. And you can see in at least 3 of those regions last week, they did level off. So there in some regions, Te Waipounamu in the South Island and Te Manawataki, the Midland region, they stayed steady or increased. Our third slide shows an update on the different subvariants of Omicron, and you can see, as expected, that the BA5 subvariant continues to become the most dominant variant, and as of the 18th of July, just over 60% of our cases were because of the BA5 subvariant, and we will expect that to continue to increase, so we'll probably see an almost full takeover by BA5 by early August. A couple of weeks ago, I shared some initial modelling from the COVID-19 Modelling Aotearoa group that showed the possible size of this BA5 wave. The modelling's been updated with 2 significant new pieces of information. First of all, there is international evidence that suggests a previous COVID-19 infection, in particular a previous Omicron infection, provides stronger than expected protection against BA5 reinfection. And second, the modelling now accounts for updated data on second booster uptake and the expected future uptake. So the slide here shows COVID-19 hospital occupancy in the updated modelling. We can see that while there is still a chance, and that is the grey bands show that hospital occupancy could still reach more than 1,000 occupied beds, we're tracking closer to a peak of 850, and we got close to that over the weekend. The numbers come down a bit. We know that hospitalisations tend to track about a week behind cases, and we have seen the cases dropping. And similarly, while the 7-day rolling average of cases could reach a peak of 16,000 a day, the model now indicates that it is more likely to peak at around 12,000. And currently, as you know, we are tracking below that, and it looks like our case numbers are declining. What is apparent is that the worst case scenario that our modellers had suggested a couple of weeks ago, with up to 1,200 beds occupied and over 20,000 cases a day, is now highly unlikely. And I'm sure we're all relieved to see this. We're continuing to mount a robust COVID-19 response, and I want to thank everybody who is taking steps to protect themselves and their whānau, not least the people who are testing when they're symptomatic, who are uploading their results, and then, most importantly, are isolating, and their family members are. This is almost certainly a key driver of this turnaround we are seeing, and it's great to see, even this far into this Omicron outbreak, that so many people are still doing this. Just on to the data we've done looking at our mortality statistics, and we are still seeing quite significant numbers of COVID deaths each day, and we will continue to see quite high numbers until case rates really decline quite significantly. To better track the risk factors of dying from COVID-19, we've done some preliminary analysis of COVID-19 attributed deaths, and I just want to share one aspect of that for you now. It shows convincingly here in Aotearoa that getting boosted is one of the most important things you can do to reduce your risk of death from COVID-19. Very consistent with the international evidence. Across the population, people not fully vaccinated against COVID-19, that is, they've had less than 2 doses, are 6 times more likely to die if they catch COVID-19 compared with someone who has had at least 1 booster dose. That's once you adjust for all other factors. Now, for people under 60, this risk is even higher, more than 13 times greater for those who are unvaccinated or less than 2 doses compared with someone who's boosted. Now, many of those who have died under 60 have had underlying health conditions, and getting boosted is particularly vital for those people. They will either be eligible now or will shortly be eligible for a 4th dose or 2nd booster. Please do so. For those who died who were between 20 and 60 years of age, we've estimated that around half of those deaths could have been avoided if all those people had been boosted. We'll continue to update and make public those analyses as they continue. Currently, around 25,000 New Zealanders on average become eligible for their 2nd booster, and our daily number of boosters yesterday was around 11,000. So there are still plenty of people who are eligible for booster doses, that 2nd booster, who can and should be going and getting it. And my message to those people is, please do so. It could save your life. Finally, from me, a comment on community water fluoridation. Fluoridation is well proven to be a safe, affordable and effective method of preventing tooth decay that benefits everybody, but particularly children. Māori, Pacifica and our most vulnerable. Unfortunately, New Zealand has relatively high rates of preventable tooth decay with very significant inequalities. Today, I have written to 14 local authorities directing them to fluoridate their drinking water supply. This is the first time that I've issued directions to fluoridate water since legislative changes last year passed responsibility for this health-based decision to this role, the Director General of Health. The time that each local authority has to fluoridate their water supply varies between 6 months and just over 3 years, depending on the circumstances of the supply currently. And these directions will take the proportion of New Zealanders benefiting from fluoridated water from 51% to around 60%. I'm very pleased to be able to do this in my last week in the job. I want to now hand over to Dr. Pete Watson, who will come up on the screen here to update on the health system response to ongoing pressures in the system. Pete, over to you.
It's great to be here alongside Ashley and Andrew today. Ashley's last week, I actually do want to take the opportunity first on behalf of the whole health system to recognise, thank and applaud Ashley for his leadership as he concludes this week in his time as Director General of Health. I know that far and wide, Ashley's presence, wisdom and reassurance provided at these stand-ups will be missed. But I also want to recognise the sacrifice that Ashley and his whānau have made in taking on what must have been one of the, if not the most challenging public service roles in the history of public service here in New Zealand. So a huge debt of gratitude to you, Ashley. And we wish you all the best as you go forth into your new chapter of your life. Ngā mihi nui rangatira. And so back to this week's update, and on behalf of Te Whatu, I can say we are all continuing to work as quickly as possible to provide all the ongoing support we can to our health system as winter pressure continues. I'm here today from Middlemore Hospital, and I can tell you my experience here and from national figures reported to Te Whatu that there's clear recognition and awareness of the really significant pressure on our health system currently. This correlates with the significant pressure and impact of Covid-19, but also the other winter illnesses, including influenza. This impact isn't just on increasing demand of people seeking and needing healthcare, but also the much greater than normal staff absences in our system due to the winter illnesses. This impact is being felt across our healthcare system, the community, primary and hospital care. Here at Middlemore, it's been pretty full on, as it often is, but it's the same across Aotearoa. We've seen high numbers of patients going to GPs and urgent care facilities, fronting up to emergency departments and being admitted to hospital. And we all are really struggling with lots of staff absence due to the illnesses. And I'm continually impressed every day with how our staff are responding to ensure safe quality care is delivered to patients and whānau. As the Director General has said, the national body suggests that over the last couple of weeks, the number of cases of Covid-19 have eased off. But in fact, in our hospitals and in our GP practices and emergency care, the pressure continues, and we expect that this will continue for some months before it eases off. It continues to place the system under considerable pressure. We are supporting our colleagues working as service providers in primary care, as well as our district and regional Te Whatu teams who are implementing on-the-ground responses required to ensure that our health system is able to manage both the demand and the risks of greater work illness. So how are we doing this? Well, the first thing is that we are part of a unified health system, including, of course, the Ministry of Health, which is working together to address these demands. We have a national plan that supports national consistency, regionally led initiatives that are locally managed. I know our Te Whatu CE, Margie Up, has spoken to this before, but I wanted to reinforce the core principles of our winter pressures operating model. These include, first, ensuring a safe and available health delivery system. 2, implementing public health measures that reflect the COVID response. On the ground, we're supporting the availability of primary and community services by expanding capacity in hours of operation, but also we very much leaned into and expanded the use of telehealth in that part of our system. We're supporting hospital flow management to optimise performance and create capacity. That's from the front door at emergency departments through to ward management and facilitating discharge. We're also very attuned to our support for our staff, to support them when they are unwell, to get well and to return to work well. We are very appreciative of our staff flexibility and support during these times. I wanted to talk about an additional step that's previously been signalled but is being introduced tomorrow to boost access to Covid-19 medicines. These are the antiviral medications, and it's very much expected this will continue to support easing pressure on our primary care and hospital care practices. So as of tomorrow, more than 400 pharmacies will be able to start supplying antiviral medicines to eligible people with Covid-19 who are at a higher risk of becoming sick, but without needing a prescription. So these are over-the-counter access to those medications. The criteria are being expanded from 2% of the at-risk population to 10%. So again, acknowledging that some people are much more at risk from becoming very unwell and requiring hospitalisations. This is about easier and more timely access to COVID-19 medicines that have been proven to reduce hospitalisation for those most at risk of severe disease. In closing, and although we have seen some encouraging signs in the COVID-19 numbers in recent days, I know that the Director General is very fond of saying we aren't out of the woods yet. And I just want to echo those. This will continue for some months. The numbers will continue to be high because of our winter pressures, and our health system, whether that's at hospital, primary care or community care, will need all the support it can get. We are coordinating our activity, seeking opportunities to reduce and manage the demand. We are sharing our successes and learning from each other, all with one end goal: to provide timely, quality care for our patients and to reduce pressure on our teams and people as they go about their mahi. Tēnā koutou katoa, and I'll hand over to Andrew.
Thank you, Pete, and tēnā koutou katoa. So I've got two things I want to talk to you about briefly this morning. The first is monkeypox, and then I'm going to talk a little bit about mask use. So firstly, I just want to confirm that there are no new reported cases of monkeypox in New Zealand, so our total currently still stands at 2. I'm not going to give any further details on those cases except to say that both are now considered recovered, so we have no known active cases of monkeypox in New Zealand. So while we have no new reported cases, unfortunately case numbers globally are continuing to rise. We've got now over 16,000 cases reported across more than 60 countries where monkeypox is not usually endemic, and that includes over 40 cases now in Australia. So concerned with those rising numbers and the different distribution from previous outbreaks of monkeypox, the World Health Organization moved this week to deem monkeypox a public health event of international concern. So just for context, a public health event of international concern is the highest sort of alert level, if you like, that the WHO can issue. There's 2 others currently in effect, one for COVID and one for polio. As a result of that declaration, we are working through the WHO's list of recommendations to ensure that New Zealand remains in the best possible position to minimise the risk of any possible community transmission here. Those recommendations include areas like implementing a coordinated response, which we're working with our partners in the National Public Health Service to do, engaging and protecting our communities, surveillance and public health measures, and clinical management and infection prevention and control. Part of that also means that we are currently reviewing our case and context definitions and the guidelines associated with them to ensure they're in line with the most up-to-date evidence as it evolves. Our public health teams have been working on planning since the start of this global outbreak back in May, taking steps to avoid community transmission here. We made monkeypox a notifiable disease in June, which has supported us and will continue to do so with enhanced surveillance and our ability to follow up cases if and when they occur. We've been in constant and regular communication with our public health units and other groups within the community, including providing updates and advice to clinicians across the country. It's important to ensure our messages to the public are regularly updated and include information about transmission, symptoms, prevention, and what to do if you develop symptoms of monkeypox, infection prevention and control measures for healthcare workers, and advice for primary care and sexual health clinics. And as I say, we're continuing to update that advice as new evidence emerges. Work continues between ourselves and Te Whatu Ora Health New Zealand and Pharmac on securing a supply of Imvamex vaccine. That's a vaccine that's suitable for both smallpox and monkeypox, and is the vaccine that is used mostly in the UK and the US. We're still finalising that supply, but it's important to note that even if we had a vaccine, the mainstay of our response would be based on many of the measures that we already have in place, including testing, isolation and contact tracing. Just to reiterate, there is no community transmission of monkeypox in New Zealand at the moment. It is not as infectious as COVID-19, but as with the early days of COVID, it's important that we understand the risk and we do everything we can do to minimise that risk now, because we'll almost certainly get more cases, particularly coming in from overseas, and the risk that they will seed into the community. As a colleague has said this week, monkeypox, although it's been concentrated in certain populations, is a democratic virus, and in those areas overseas we're starting to see cases in much wider groups of the population, so important to be really vigilant. Finally, just wanted to make an additional plea for mask wearing this winter, and just to show you, we've got a new graphic which will be up on social media and other channels later, which really just makes the point about mask use and the restrictions of transmission that helps with, and really makes the point that, you know, one mask is good, two masks are better. And although this is based around COVID, as we've said many times before, there are lots of respiratory infections out there at the moment, lots of things that are transmitted via respiratory droplets and aerosols, and masks are a great protection against all of those things. Now the school term has begun, we're also strongly recommending, as we mentioned last week, that face masks are worn at schools and kura for students years 4 and above for the first 4 weeks of this term, which will get us through the worst period of winter that we have to go. The Ministry has previously provided advice to Government which resulted in the provision of funding for free masks for students and additional funding for schools and ECEs to support better ventilation over the winter months. The first 4 weeks will see us through this current period of winter illnesses and increased COVID-19 cases, and we are asking students to wear masks in all indoor settings where they can, but of course there will always be activities where face masks aren't practical, such as while eating and drinking or while playing sport. We know correctly wearing an appropriate mask, such as surgical and N95 masks, can reduce the risk of transmission by up to half, that you will spread COVID-19 or other respiratory viruses. And I would refer you back to the Director General's video on how to wear masks appropriately, which is available from our website. Now I'm just going to take advantage of being in front of the microphone to also go off script a little bit, as Pete did, and offer my thanks and acknowledgement to Ashley. For those of you that are counting, we think that this is Ashley's 307th stand-up, which is, I think you'll agree, a Herculean effort, and just a testament, I guess, to the incredible work that he has put in right since the beginning of the pandemic. Many of you may not be aware that at the weekend Ashley was at the GP conference in Christchurch, where he was awarded an honorary fellowship of the Royal New Zealand College of General Practitioners. Those honorary fellowships are only given to people who've made an outstanding contribution either to general practice or the medical profession in general. He was nominated for his tireless work as the Director General of Health and using evidence-based decision-making to inform government. In their citation, the college said Ashley had communicated with vulnerability, honesty, compassion and logic, and reinforced public health messaging by being a strong role model. In presenting the fellowship, College President Dr. Samantha Merton thanked Ashley for his calm, steadfast approach over what we all know has been an unprecedented few years, and for his advocacy for GPs and the rural hospital medicine workforce over the course of the pandemic. I think we would all agree that in place of GPs and rural hospital medical workforces, you could exchange that for almost any other section of the health sector, or indeed society at large, and find the sentiment expressed by the college rings true for all of us. I'd personally like to offer my thanks to Ashley, although perhaps not for handing the baton of media stand-ups, and wish you all the very best for the future. Thank you, Ashley. Go well.
Kia ora, thank you Andrew and Pete for your updates and also for your very kind words. Well, as mentioned, this is my last press briefing as Director General of Health, so I want to do one last thing, and that is to thank all of you, the news media. An effective COVID-19 response has relied fundamentally on and continues to rely on an informed public. Throughout the pandemic, people have been able to open their newspaper, switch on the TV or radio, check their phone, to be informed about what COVID-19 means for their lives and how to act. And an important role for the media is to hold those in public office to account, to ensure we are not just doing our job, but constantly challenged to do it better. From where I've been standing, it feels like you have fulfilled that responsibility. It feels like an age since we hosted our first press briefing in January 2020 in the room next door to here. I don't know how many, if any of you were in the room then, but some, I'm seeing some nodding around here. That was to discuss the novel coronavirus emerging in China. Since then, we have been through lockdowns, many different COVID-19 variants, rolled out vaccines several times to over millions of New Zealanders, and learned a whole new vocabulary, from household bubbles to rats. I feel honoured to have led the Ministry of Health at this time, and I am wholly confident in the people, including those who are here with me today, across the Ministry and to Whatu Health New Zealand, who will be leading the COVID-19 response into the future. And I'm happy to take questions for the last time.
Dr. Bloomfield, why aren't you making all the councils fluoridate their water? Why just 14 at this stage?
Yes, so on the topic of fluoridation, we wrote to all councils who currently do not fluoridate their water to ask of them how long they thought it would take to fluoridate their water and how much it would cost. On the basis of the responses we had from the councils, we then triaged those who felt they were able to do it sooner and for whom the cost could be accommodated within an envelope of around $11 million that we have available to support capital works that will allow them to fluoridate. And so we've started off with that first group of councils, but rest assured I have written to all of them, and in particular some that have got quite large populations receiving unfluoridated water, and made it very clear to them that we will be following up with them to also look to fluoridate their water in the near future.
What's the time frame on this? When do they have to do it by?
The 14 that have received the directive today, will be receiving that directive, will take anywhere between 6 months and 3 years, depending on the nature of their current supply and just the extent to which they need to install plant. Some of them have got the plant there ready to go, so it's a much shorter time frame for starting to fluoridate.
How important was it for you to issue this order in your last week in this role?
I've actually been a long-time champion of fluoridation. It's an incredibly effective, one of the most cost-effective public health interventions. And one of the things about it is it's a great way to address inequities in outcomes, and particularly amongst children. And so I'm thrilled to be able to give these initial directives under the new legislation before I finish up.
Given the issues that Wellington Water has faced with fluoridation, how urgent is it that the capital gets fluoride back in its water supply?
Yes, well, I've been kept well up to date with the efforts to not just investigate what happened here in the capital, but also to remedy the fact that they haven't been fluoridating, and that work is progressing apace. I'll have to come back to you on the actual time frame for when fluoridation will be reinstated to a couple of those specific supplies. There are many Wellingtonians who are still receiving fluoridated water, but there are a couple that it needs to be reinstated in, and I know progress has been made apace.
How concerning was that development that came out about the independent probe and the issues that Wellington Water's faced over the last 6 years?
Well, it was very concerning, and underscores both the importance of the legislative changes, but also the importance of local authorities maintaining a clear oversight of fluoridation of their water and regular reporting on the status of that.
And how urgent is it that these councils that you've mandated to get fluoridation do this as soon as possible?
Well, I'd encourage those councils and the ones that I haven't yet directed to fluoridate their water as soon as possible. They don't need to wait for a direction from me.
What's the latest advice on the COVID-19 vaccine for under 5s?
Sorry?
For under 5s, what's the latest advice on the COVID-19 vaccine?
Well, some countries have approved vaccination for under 5s. mostly to date with the Moderna vaccine. We haven't yet had an application for vaccination of under 5s. With the Pfizer vaccine, we don't have Moderna here in New Zealand at this point in time. Once we receive an application, we will assess that, but also we are continuing to look at the emerging evidence, and our technical advisory group, Vaccination Technical Advisory Group, will provide advice on the balance of risks and benefits of offering vaccine to that group. It's a good question.
Yeah, and so as you are passing the baton, how comfortable are you with where you're leaving the COVID situation, and is there a pathway out of the woods that you see ahead?
Indeed, out of the woods. Look, as I said, I'm wholly confident in those who will be continuing to lead and deliver the response, and two of those people are here with me today, but there are many others, and many of the teams that have been doing the work in the ministry have transferred now to Whatu Health New Zealand, but it's the same people, and they're very able and will continue to do a good job. Like every country, we're of course keeping a strong forward view on this, and looking for what is the pathway to reducing the impact of COVID-19 both on people's health as well as our health system and wider society. And so the only other comment I would make is it's very important that we do continue to maintain all the measures that we have got in place for the time being, especially as we get through winter. And you will see globally that even in Northern Hemisphere countries in the middle of summer, COVID continues to have a significant impact, including on health systems. And we clearly want to keep every tool in the toolbox that we can to avoid getting ourselves into that position as we come out of winter.
Just briefly, could you talk about the biggest changes in your thinking about COVID over the last 2.5 years? I mean, I remember being at one of those early press conferences, for instance, when you said there was no evidence that mask wearing would help, things like that. So.
Yes, well, quite, and this is the one of the beauties of daily stand-ups is that one is forced to sort of be humble in this role. Look, what I would offer is that we've kept really up to date with the emerging evidence and not hesitated to change our advice where we see new evidence. And sometimes, of course, we've had plenty of external commentators who have been suggesting we should or shouldn't be doing certain things. But of course, the responsibility we have is not just to look at that evidence, but to think about what are the implications of that, and most importantly, how do we make sure we implement any changes effectively? One thing I would say, and I was speaking at a conference over the weekend in Sydney, where it's compulsory to wear masks on public transport. Now, obviously, compulsory in New South Wales means only about 10% of people need to wear masks. So it's very important here in New Zealand that we continue to do things and take people with us. And I've made this comment before about the role of mandates or not mandates.
Biggest regret, biggest success this time?
No regrets in the sense that we gave the very best advice we could based on what we knew at the time. One comment I would make, and this is a really big lesson for me and something I think others have learnt as well, we tend to underestimate the capability and capacity and resourcefulness of our communities, and in fact, providing them with the resources and the information to get on and do the right thing can lead to enormous success. And I think again, a great part of our success as a country has been the way that communities have responded to the information that's been provided, and then the resources we have provided either directly or through a range of providers. So I think there's a great lesson there for us that actually our biggest healthcare workforce are our citizens. They deliver most healthcare every day to themselves and their families and their communities, and our job is to sometimes get out of the way and make sure they've got the support they need to do so. There's a question here.
How many councils in New Zealand aren't currently fluoridating their water?
Oh, sorry, I don't have the number there, but one of my team will be looking that up right this minute to provide it to you as soon as possible. But I do want to emphasise the point. This is a safe, highly effective, highly cost-effective intervention, and councils don't need to wait for a directive to get on and protect their most vulnerable citizens from tooth decay.
And what kind of responses did you get from those councils when you issued this directive to them? Because some of them have been quite famously anti-fluoride.
Yes, variable responses, and some of the large ones I personally rang the Mayor, and again got responses that ranged from great enthusiasm to much less enthusiasm for that.
And when would you hope to, to get that? Like, this is going to be 60% of New Zealand water fluoridated. So when would you hope to get to 100? And is that achievable?
It's not achievable to get to 100 because many of our water supplies are much smaller supplies supplying small communities, and it's really more difficult and not cost effective to fluoridate those supplies. So other mechanisms need to be used there. But if we get all larger water supplies fluoridated, then we will get up to, I don't have the figure, but I imagine closer to 80% of New Zealand is able to access fluoridated water.
And when would you want to get to that point? Because you've said that some of those councils you haven't issued a directive yet.
As soon as possible. Yes. I'll just go down.
Thank you. Where are we seeing the most pressure at the moment in terms of winter illness? The South Island was mentioned earlier, but can you be more specific in terms of hospitals and regions?
That might be a good question for Pete. Pete, did you grab that question about where's the greatest pressure around the Whatu at the moment?
In terms of winter illness, I think it's pretty spread actually. I don't think there is a particular, it's in the north or in the south. I think it's right across actually the country currently we are seeing. So which is slightly different to what we've experienced before, where it may have started, for instance, often in the Auckland metro area and then rolled south. But at this point, I think it's pretty well spread. And so both in Southland, we know the particular areas, and Canterbury, but all the way through into the northern region. So, I don't think there's a particular geographical region where we are seeing more. And it does vary, over time often. And so I think that's the pattern we will see now, that there's a more consistent pressure across the system.
Just which hospital question?
Which
hospitals are only doing acute surgery?
All hospitals are doing if you're saying the opposite, some are all doing some planned care, but the amount of planned care is prioritised depending on what their capacity is. So I'm not aware of any hospitals that are not doing any planned care, but the most urgent planned care is being prioritised where they are having to ensure that they've got enough capacity for the winter pressure.
So we're just told tomorrow with the anaesthetic technicians striking, there will be disruption for the hospitals that they predominantly work in. I know Middlemore's not part of it, but how disruptive are you expecting that to be for surgeries?
So we're making preparations, as we always do with any strike action, to ensure that the safety of clinical care can be provided. So, we aren't experiencing any here, but I do know that across some other areas, other districts, there will be. And we are looking forward actually to, being able to get through this period of industrial disruption, which is really challenging at a time when, we've got such pressure from the winter illness. But look, if we've got further questions about that, we can provide a more detailed statement following the stand-up.
Thanks, Pete. There was a question down here.
On the COVID deaths, Dr. Michael Baker said that likely a very conservative count, given some older patients might not be tested. Do you agree with that, and it could actually be much higher, the true death toll from COVID?
Well, we've got quite a high level of confidence in the numbers because every one of the numbers that we're now providing in our total has been recorded as a death from COVID or related to COVID on the death certificate, and then our coders have gone through and made sure that that is then reflected in our numbers. So I would say New Zealand's got as good a tally of this as any country has. But also, of course, we are still collecting the number of deaths, anyone who dies within 28 days of an infection. And so those where there's uncertainty are looked at carefully to see if COVID could have been a contributory cause. So I would say we've got a pretty good estimate. The other thing is, and I'm sure Professor Baker talked about this as well, is that we're also looking concurrently at if there's any evidence of excess mortality here in New Zealand, and that would give us a further indication if there were COVID-related deaths that perhaps were over and above the deaths that we would otherwise expect.
And how is that currently tracking?
At the moment, my understanding is that we're not seeing excess mortality, but we can provide an update on that next week.
And also just, looking for whichever number it is, there's obviously a very large number of people dying from COVID, daily. If this was the road toll, would there be a lot more intense coverage, I guess, of it. Are you able to say a bit more about the people that are dying here and just, there's a bit of a maybe misunderstanding that some people, maybe had other illnesses that were dying from, and so there's not so much attention given to it. But yeah, you able to explain a bit more about that?
Yeah, so every death from COVID-19, of course, is a great loss to a family and a community. And what we can say is, as in other countries, we see the highest rates of death amongst older people, so age is by far the strongest risk factor. But we also see that pre-existing other conditions, particularly heart or respiratory conditions, also predispose people to dying from COVID-19. So saying, I do want to focus on the information I did give, which is showing that just how protective vaccination is, and particularly if people are boosted. It's a great intervention. It's and something that everyone can do to reduce their risk of hospitalisation or death from COVID-19.
There's some concern in Australia as to the efficacy of RATs, and a product that we have approved here has been taken off the shelves over there. Are you going to be, will someone be reviewing the efficacy of RAT testing here? Are you looking at removing that same product here?
Yeah, we'll keep a close eye on just what other countries are doing around products, and if they've got concerns about specific products. I don't have the detail around that one, but what I would say is since we started the rollout of rapid antigen testing here in February, they've served us very well and continue to be a really key part of our response. And again, just to thank everybody who is using rapid antigen tests. I think it's become a part of what we do, and the fact that we're still providing them to and getting 90% of people crossing the border doing that rapid antigen test day 01 and then uploading the result is great.
How many PCR stations are still open, and how does that compare with the peak of capacity?
Well, I couldn't tell you exactly how many stations are open, but PCR testing is still widely available, and of course it can be done at general practices as well as the dedicated stations.
And how staffing levels across those stations? Are they under pressure?
No, they're not under pressure. And of course one of the things we're doing is making sure that we're not overstaffing those stations when actually we're not using PCR testing quite so much. When we could use those staff in other parts of the system. Perhaps just a few more questions. I'll go here first.
Weeks ago, you announced a couple of health changes, particularly around availability of the flu vaccine and COVID-19 vaccine. Are you confident that those changes have had an impact and have reduced the case numbers and the load on hospitals as well?
I think they're definitely playing a role. So far, we've got about a third of eligible people eligible for that second booster have taken it up, and that's several 100,000 people, so that's great. That will be making a difference. Likewise, our flu vaccination rates continue to increase. Again, there's still merit if you're eligible for a flu vaccine and going and getting one. So all these will be contributing, and we have seen our rates of flu in the community have declined over the last few weeks as well. And
also just back on the fluoride, obviously $11 million has been made available at the moment to help those councils put fluoride in their wood. Would you like to see more funding for it?
Well, that's something we will be looking at what further financial support might be needed and might be available in the future for further councils to fluoridate their water supply. Down the back.
In relation to nursing students working at Dunedin Hospital, the Nurses Organisation says families of patients should be brought in to help instead. What's your view on that? Is that acceptable?
Well, I'm going to pass to Pete, but in my experience, families are already and do play a really important role already in supporting the care of their loved ones when they are in hospital. Pete, did you want to respond to that?
Yeah, kia ora, Ashley. Yeah, that's right. So whānau play a really important part in being healthcare partners in hospitals already. But in addition to that, to try and support the staffing issues that we are facing, we have been looking to others, including student nurses, to support with non-clinical tasks on wards for when people are available and the need arises. And we're using that flexible, but Dunedin is one place where that has been happening. So such activities as supporting, assisting with mobilising patients, hygiene meals, those sorts of non-clinical things, which many of those nursing students, I understand, are towards the end of their degrees and can help with. But I just want to reassure everybody that where this is happening, it's under the direction and delegation of registered nurses. So this has been well supported and supervised where this is occurring.
Thanks, Pete. And could I just make a comment on students? Many of our nursing, medical and allied health students over the last 2 or 3 years have really had their educational experience disrupted, and they've been fantastic. They've played a critical role in supporting the Covid-19 response, many of them in hospitals, supporting testing, supporting the vaccination rollout as well. So I do want to just take the opportunity to thank them for what was really quite a disrupted educational experience, but they've really pitched in and played quite a key role over the last few years, and want to thank them for that. Sorry, follow-up question.
I was just going to ask, how many hospitals, it sounds like that's quite common then, how many hospitals is this happening at around the country, having student nurses and working?
Pete?
We need to get back to you on that. I wasn't specifically talking about student nurses in that regard. I was talking about the use of staff more broadly within the hospital. So, for instance, here at Middlemore, we have our tasking teams where people volunteer from one area to help in another area, both in those non-clinical tasks areas. So it's an internal process. And so that's something that has been found to be a useful additional approach when we are really facing challenges in terms of our normal rostered clinical staff on wards.
Great. Down the back, I think there was a follow-up on that, wasn't it? Yeah.
And you were saying with nursing students that you're, grateful for their work, but when it comes to those students, they have to do 1,100 hours of clinical work and it's all unpaid. Do you think that's fair, given that we're trying to get more nursing students through the system and into the workforce?
So, yes, student experience as part of their education is unpaid, not just for nursing students. However, we know that for some students that does create a real financial pressure, and it could be something that's contributing to dropout during their study. I know that is one of the things that has been looked at as part of future workforce initiatives. There was a question.
How concerned are you about the level of deaths in 80 plus people with COVID? It seems to have been quite a spike in recent weeks.
In people over 80?
Yeah.
Yes. Certainly our highest death rates are in our old, so those over 80. That's something we keep a very close eye on, and a real priority for getting that second booster dose out has been into our older age groups, in particular those in aged residential care settings, because we know that they're at the highest risk of dying and therefore the greatest benefit of vaccinating them. So that's a big focus. I'll come back to you and we can get a breakdown of vaccine coverage by age group and we can provide that.
What advice did you get from officials after asking them to look at the red setting?
The advice I got has been passed through to ministers and is currently being considered, so I don't want to preempt that consideration in any decisions that ministers make. Thank you.
Would we be for a monkeypox vax as well?
Sorry?
A vaccination for monkeypox. What stage are we at for rolling that out?
So we're still working on getting that vaccine for New Zealand, and those I think Andrew talked about that the discussions that Pharmac is leading with the manufacturer are going well, but the point here being at the moment we've got no active community cases, and vaccination might play a role, but it's not the first measure that we'd implement if we did have any community spread here of monkeypox. Any final questions?
What's next for you,
Lunch, but from Saturday, a jolly good break. And thank you very much. Can I thank you again? That's over and out from me.